acute inflammation is a process in which the body is either having an injury in the form of cuts, lacerations or stabbing, or we are exposed to chemicals which are going to test our immune system by chemical irritants, adverse weather conditions in the form of cold weather which produces a frost bite. It could also be because of allergic reactions, could be because of external stimulation due to burns or high temperature, or infections. All these result in acute inflammation. This inflammation helps us to prevent sequelae due to injuries or due to infections. It can result in two outcomes. Either it will result in repair or it would result in some sequelae. The repair, it happens, it would limit acute inflammation, but if this stimulation which has causing this acute stimulation is persisting for a long period of time, it will convert this acute inflammation to chronic inflammation. Chronic inflammation, as the name indicates, it is when the stimulation is persisting for a longer period of time. It results in so many changes which produces certain disease states. The important disease states which could happen as a sequelae to chronic inflammation are, it could result in autoimmune diseases. When the inflammatory cells or mediators which have activated some cells, they are trying to destroy the normal body tissues. Here, the body perceives these cells as those which are causing a pathology and tries to destroy them. It could also result in diseases like rheumatoid arthritis. It can result in Alzheimer's disease. It can result in malignancies. It can result in cardiovascular diseases and even autism, some neurological diseases, and it can even cause depression. So remember that whenever we have acute inflammation, it needs to be taken care of. If it does not get resolved, it might result in chronic inflammation which can have far-fetching consequences, resulting in disease states which would be requiring therapy for very long period of time and even lifelong. Now, the body tries to warn us whenever there is an inflammation. This is a classical picture that you see which talks about the 5 features of inflammation. The first feature is heat. Heat is because of vasodilatation. There is acute inflammation. There is increase in the blood flow. There is redness. It is itself explanatory. It is again because of vasodilatation. There is increase in the blood flow. The body is trying to use these processes to remove these stimulants or antigens or some factors which are causing inflammation away from them. The third feature could be swelling, which is because of release of or diffusion of fluid from the vascular compartment into the extravascular compartment, resulting in increase in mass which manifests as swelling. Obviously, all these things are interrelated with the release of mediators which cause pain. And if we have pain at any site, it would also result in loss of function. So remember, there is heat, there is redness, there is swelling, there is pain, and there is loss of function. These are the 5 features at a site of inflammation. Now try to understand a bit deeper so that we can understand what are the points or what are the drug targets that would be effective in controlling or reversing this inflammation. Remember, we are provided with one of the largest barrier, that is our skin, which takes care of most of these irritants which are there. In case of some infection which is able to cross this skin barrier, there is a cut, there is injury, there are environmental factors, heat is applied over here because of hot weather, or we are going to be exposed to, or there are burns because of exposure to heat, or there is a frostbite which is there. It results in the cardinal signs that I have just discussed to you about, that is rubor, calor, dolor, tumor, and loss of function. These result in release of mediators, As I told you, it first results in acute inflammation, and in acute inflammation, the most effective drugs are the traditional anti-inflammatory agents, that is, non-steroidal anti-inflammatory drugs. This, if not corrected, can result into chronic inflammation, which can produce a number of diseases, as we have discussed or elaborated in the beginning. So, remember, what are the acute mediators of inflammation? These are histamine, serotonin, prostaglandins, leukotrienes, platelet activating factor, tumor necrosis factor, interleukin 1, complements, kinin, and proteases. If they are taken care of by the involvement of neutrophils or monocytes, this event is over. But in case it keeps on persisting, it results in chronic inflammation, and the various other mediators which could be further aggravating this response is the release of mediators like leukotrienes, nitric oxide, reactive oxygen species, platelet activating factor, ICAMs, that is adhesion molecules, complements, and proteases. As I mentioned, it could result in two outcomes if it is able to eliminate the microbes or tissue over here. It results in improvement or care, or it could result in repair process which would mend the changes which has happened because of the release of these mediators. As you see, one of the common thing which is very important, which further aggravates this whole thing, is prostaglandins. How are prostaglandin forms? We all know that membrane phospholipids are acted upon by phospholipase A2, which produces arachidonic acid. This arachidonic acid can be acted upon by two set of enzymes. One is 5-lipooxygenase, also called as 5-LOX. It results in production of 5-heptate, which ultimately forms leukotrienes. So as you can see that 5-LOX acts on arachidonic acid to result in the release of leukotrienes, and leukotrienes are also important mediators of inflammation. Arachidonic acid is also acted upon by cyclooxygenase, which results in the production of prostaglandins, that is prostaglandin G2, as you can see over here, which is then further acted upon by prostaglandin H synthase, which converts it into prostaglandin H2. And then there are specific synthases which produce a wide variety of these chemicals like thromboxane A2, prostacyclin or prostaglandin I2, prostaglandin E2, prostaglandin D2, and prostaglandin F2 alpha. Now, why it is important to know that there are so many different types of prostaglandins? Because depending upon the type of prostaglandin, we get different responses. For example, thromboxane A2, it increases platelet aggregation and causes vasoconstriction, meaning thereby it would block the blood vessel. There could be also action of prostacyclin I2, which is opposite to thromboxane A2, that is, it decreases platelet aggregation, it increases renal blood flow, thereby causing vasodilatation. It also inhibits gastric acid production. Prostaglandin E2 increases renal blood flow, causes vasodilatation, and because there is increase in renal blood flow, it could also cause natriuresis and also causes inhibition of gastric acid production. Prostaglandin D2 also increases renal blood flow. It also inhibits gastric acid secretion, and prostaglandin F2 alpha, it decreases progesterone, increases uterine contraction, causes vasoconstriction and bronchospasm. So what we see that because of the release of prostaglandins, there is increase in the blood flow because there is vasodilatation, and which is responsible for three major things. Vasodilatation results in redness, it results in swelling, vasodilatation results in heat, it results in swelling, it also results in erythema. So these are the three features which are there because of vasodilatation. As you can see, it is contributed by the various prostaglandins over here. Okay, but thromboxane A2 and prostacyclin I2, they have opposite effects to each other. This cyclooxygenase exists in three isoforms, which are called as cyclooxygenase 1, cyclooxygenase 2 and cyclooxygenase 3. Now let's first understand what is the difference these three cyclooxygenases. The cyclooxygenase 1 is the normal constituent. Therefore, it is responsible for maintaining the body homeostasis in the stomach, in the intestine, in the kidney, as well as in the platelets. Cyclooxygenase 2 is inducible, meaning thereby whenever there is exposure or whenever there is stimulation, the expression of cyclooxygenase increases many folds. It is responsible for body homeostasis, which is expressed through macrophages, synoviocytes and endothelial cells. In addition to this, cyclooxygenase is a normal constituent which is present in the CNS, in the kidney and female urinary tract. The cyclooxygenase 3 is also a normal constituent which is affecting the CNS, the heart and aorta. Modification in this could result in pain, fever, hypertension and GI effects. Now we see that there are three types of cyclooxygenases which are acting on arachidonic acid. COX-1 is normal constituent, COX-3 is also normal constituent, COX-2 is inducible. So we have the drugs like non-selective drugs which are anti-inflammatory. As you can see that prostaglandins, leukotrienes, they are responsible for producing inflammation, and therefore any drugs which inhibits inflammation is called as anti-inflammatory. So the drugs which inhibit COX-1 and COX-2, they would be called as non-selective because they do not differentiate between COX-1 or COX-2. Whereas there are specific drugs which have now been developed which are acting against inducible COX-2. As I said, the normal constitutive COX-2 is important as it's a normal constituent in the CNS, in the kidneys over here. But once it gets induced, there is overexpression, which would be resulting in increased manifestations of inflammation, which needs to be controlled. And therefore, we have drugs which are specific for COX-2, and these are called as selective COX-2 inhibitors. Lastly, we have only one drug which acts specifically on COX-3, that is acetaminophen, which in India is also called as paracetamol. Another way we can block COX-2 is the use of corticosteroids, that is glucocorticoids. So it means that the production of prostaglandins from arachidonic acid can be blocked by three important group of drugs. The first is the non-steroidal anti-inflammatory drugs, which could be a COX non-selective, or it could be COX-2 selective, or it could be COX-3 selective, which is paracetamol. The second drug which could affect prostaglandin synthesis is glucocorticoids. So we will see, therefore, that when we talk about uses of corticosteroids, we put their uses as hormone replacement therapy and also their uses as anti-inflammatory uses. And it is this anti-inflammatory action which is produced by inhibition of production of prostaglandins from arachidonic acids by corticosteroids. Now look at the classification of non-steroidal anti-inflammatory drugs. So therefore we can classify non-selective anti-inflammatory drug based on two parameters. One is chemical structure and the second is site of action. As you have seen that inflammation is a protective process in which the body tunes itself either for destruction of the stimuli which is causing inflammation, for example pathogens or bacteria or microbes, or it induces a repair so that whatever damage has happened, it is taken care of and it does not result in sequelae, which could also include conversion of acute inflammation to chronic inflammation. you can see a large number of diseases which are a result of either acute inflammation or chronic inflammation, and therefore all of you must have used some non-steroidal anti-inflammatory drug more than once in your life up till now. As the use of non-steroidal inflammatory drugs is very common, it's very important to have a classification which is on the chemical basis, so that if somebody is hypersensitive to one of the constituents, one needs to know what are the other drugs that he or she needs to avoid. Similarly, from a pharmacology or therapeutics point of view, you need to understand that which drug inhibits which cyclooxygenase. Thereby, you can predict what could be the beneficial effects of such combination, what could be the adverse effects, and in which situation to use a non-selective agent versus a COX-2 selective agent versus COX-3 agent, that is paracetamol. So first we have non-selective cyclooxygenase inhibitors. So based on chemical classification, it can be divided into various subgroups. The first subgroup is salicylic acid derivatives. It was one of the first analgesics which was discovered and has been used for nearly a century. This includes aspirin. Other salicylic acid derivatives which are used in therapy are sodium salicylate, sulfasalazine, all-salazine, and diflunisal. The second chemical group is para-aminophenol derivatives. This includes paracetamol, which is also called in the West as acetaminophen. Please remember, it is the same drug which is having two different names. One on this side of the world, here we call it as paracetamol. It is the same as acetaminophen. Then thirdly, we have indole derivatives, which includes indomethacin, Solendec, and atidolate. So just remember at this point of time that atidolate has more preference for inhibiting COX-2 than COX-1. So therefore, if you perceive that there is overexpression of COX-2, we can use atidolate where it would be having a preferential binding to COX-2 over COX-1. It means it will bind to COX-1 also, but most of it will be binding to COX-2. The fourth is heteroaryl acetic acid derivatives. This includes diclofenac, tolmetin, and aceclofenac. It is very important group of drugs which is used commonly in our country, diclofenac and aceclofenac. The next group we have is pyrrolopyrrole derivatives. Here we have ketorolac. It is the one which is given parenterally. Then we have propionic acid derivatives, which are considered as one of the safest drugs, like ibuprofen, naproxen, flurbiprofen, ketoprofen, and so on. Then we have anthranilic acid derivatives like mefenamic acid, meclofenamic acid, which are, in addition to having anti-inflammatory, also have anti-spasmodic activities. Other non-selective COX inhibitors are enolic acid derivatives, which are also called as oxycams. Here we have piroxicam, tinoxicam, and remember, meloxicam is also having a preferential COX-2 inhibition as compared to COX-1. Then we have alkones like nalbumiton, which is relatively gastroprotective. We have pyrazolone derivatives like phenylbutazone, oxyphenbutazone, and azaprozone. These are not used very commonly these days because they carry a risk of producing bone marrow suppression. So we have safer drugs available. So therefore, phenylbutazone and other derivatives or other members of pyrazolone are not used very commonly in our country. So what we have seen now, that we have talked about group of drugs which are non-selective, that is, which are blocking both COX-1 and COX-2. We have two agents which are preferential COX-2, which includes atidolate and meloxicam. Now we talk about another group of drugs which are non-steroidal anti-inflammatory, which are selective COX-2 inhibitors. This includes the most important group, which are called as COXIBs. They were the groundbreaking drugs which were binding to COX-2. The reason why we wanted to look for there was that when we are using non-selective agents, it mainly results in GI irritation, which increase the risk of peptic ulcerations. So therefore, we were trying to find out drugs which will produce relatively lesser GI manifestations, and we found that if we are able to block the COX-2, we would be having a relatively safer drugs for the GI. But it led to another set of problems, that they had higher chances of cardiovascular and stroke risk. So the agents in this group include celecoxib, etoricoxib, pericoxib. So there is a coxib postfix to these agents. A few of these agents have already been withdrawn because of increased chances of acute myocardial infarction and stroke. Then we have indole acetic acid derivatives that we already talked about, etodolac. Then we have sulfonilamides like nimesulide. Now it's a very important drug to remember that nimesulide has been banned in most of the countries because of risk of hepatotoxicity. But in India, still it is available, but therefore one must be using it very cautiously. And lastly, we have oxycam that I already talked about, meloxicam. So meloxicam, etodolac, they are the ones which are having preferential